Thank you very much, Neil. Our second speaker this evening is Dr. Danielle Martin, practicing family physician and Vice President of Medical Affairs and Health System Solutions at Women's College Hospital. In her new book, Better Now, 6 Big Ideas to Improve Healthcare for All Canadians, Dr. Martin advocates for changes that need to be implemented in our healthcare system in order to improve it and provide equitable access to healthcare for all Canadians. Her talk is titled, Big Ideas to Improve Healthcare for All Canadians. Please join me in welcoming Dr. Danielle Martin.
Thank you, Richard. Thank you, Neil, for participating this evening. I'm really excited to be here. I've been thinking about this question of health system improvement and what should guide us in this conversation, because of course, there are so many considerations. You know, there's this conversation about the aging of the baby boomer generation. There's the conversation about what's the appropriate role for industry. There's the conversation about the shifting face of immigration to Canada and what does it mean to provide culturally competent and appropriate services in an increasingly diverse urban environment. There's the conversation about the needs of rural Canadians, people living in remote communities, Indigenous peoples, and of course, ongoing conversation about what's the appropriate role for healthcare providers. And by the time you finish listing the problems, you're exhausted. And it's hard to figure out where to begin. And so I'm going to propose a frame for this conversation, which is one that I've been thinking about a lot, one that sadly I think many of you in the crowd under the age of 40 will not relate to, which is the notion of bifocal vision. I want to talk about how do we see clearly what our objective is or should be in healthcare. And the argument that I try to make is that we need the capacity to see simultaneously, both at the level of the individual person, the human being, often someone who is sick, feels vulnerable, is trying to navigate an extremely complex and sometimes indecipherable system, a person who needs and deserves to have a decent experience and feel respected and have some dignity in the process of accessing healthcare services, a person who deserves to have access to something that is consistent in its outcomes. And at the same time, we need to be able to zoom out and look at the population, look at the bigger picture of what does it mean to have a health system that is sustainable and affordable for all of society over time. What does it mean to provide services that actually improve the health of a population, not just an individual, which is a difficult test to meet? And we need to somehow hold both of those things simultaneously in order to guide this conversation. So I begin from that up-close, one-on-one interaction, because as you've heard, I'm a family doctor. And that is actually, if you strip me of all kinds of elements of myself, when you get to the core, you will find that. It is sort of what anchors me in my work. And so when I think about what I want in a healthcare system, I think about my patients and what I think it is that they want and deserve. But I'm also not just a family physician, I'm a mom, and I'm a daughter, and I'm a granddaughter. And I do think it's important when we talk about healthcare system transformation and change that we be clear about the impact of any decisions that we make on actual people who are trying to access services in the system. And so I begin by sharing with you the story of my own family, a story which I tell in this book that you've just heard Richard mention, and which I've been telling actually. It's a strange feeling to tell such a personal story over and over again, but I've been doing that over the last several months as I've been traveling across the country talking about this book, and it's a weird form of therapy. The story doesn't belong to me, it belongs to my grandmother, whose name was Sarah Shilton, and who arrived with her husband, Jacques, and a family of 10, 3 generations in tow, at Pier 21 in Halifax in December of 1951, from Cairo. Richard, who was making Egyptian references earlier tonight. So you can imagine what it's like to arrive in Halifax in December from Cairo. It was chilly, and they got off the ship and got on the overnight train to Montreal, which is where they were going because they spoke French. and landed there 3 generations, as my mom tells the story, with a couple $100 and several trunks of totally inappropriate clothing. So they settled in Montreal and began to try to build a life for themselves, as so many families have done. And it was mostly up to my grandfather to kind of make this thing work. He was the primary income earner in the family. He was a very educated man. He spoke 7 languages, very talented musician. And he was in it for the family to build a new life in Canada, until about 18 months after arrival, when he went to visit a friend at the Montreal Jewish General Hospital, which those of you who know Montreal will know every hospital somehow is located at the top of a hill, usually a hill covered in ice 365 days of the year. So he hiked up a hill to go and visit a friend, and while he was waiting in the waiting room, he had a massive heart attack, quite unexpectedly. He was a young guy. And thus began my family's journey through the healthcare system in Canada in the days before Medicare. After 9 weeks in the hospital, he was finally discharged and essentially experienced a decade of downward spiral of his physical and mental health. And as he became weaker and experienced more respiratory difficulties and had more trouble walking because of the pain in his legs, the bills just piled up. Doctor's bills, the cost of medications, which he would sometimes take when he could afford it and sometimes not. That's something that hasn't changed much. And sometimes would visit the hospital and sometimes wouldn't, depending on how the finances were. And the stress on my grandmother was intense, such that actually at a certain point she suffered what was known in those days as a nervous breakdown and ended up herself being hospitalized for 6 weeks. It was an ugly time for the whole family. And it ends, the story, not nicely, with my grandfather's death in the year 1966, at the age of 54. 1966, which you'll remember from our history, was the year that Parliament passed legislation in Canada to put in place universal health care. So I ask the question in the book and in talks like this one, what would have been different if Medicare had existed in Canada for my family just a generation earlier? And I think the answer is it would have changed everything. That is where we begin this conversation, from the values that Neil was talking about. The notion that medical care is about more than just being able to access a doctor or be admitted to a hospital, that it's about what it means to be a society where we embrace very basic fundamental values. Are we there for each other when we're at our most vulnerable? Do we place well-being ahead of wealth? And I will say that in the setting of the conversations that we see happening south of the border today, I do not believe that these are questions, the answers to which we should ever take for granted. So we can begin from those principles, and they're critically important. They matter at the individual level, and they matter at the social level. But at the end of the day, we have to make a decision about whether we believe as a nation that our support for the principle of equity means that we're going to be okay with the mediocre. And I don't believe for a second that we need to choose between equity and excellence. I think we can have both. I think we deserve both. I think we should demand both. But we need to be able to handle the difficult conversations that take place, because too often the debates in our healthcare system come back to 2 very entrenched positions. One which says, oh, Medicare, it was a nice idea, back in the 60s when we all believed in that hippie stuff. But now we're gonna have to grow up as a country, right? And get with the program, and not everybody can have access to everything, and we're gonna have to make some choices. And thereby sort of, it's the pat on the head, which I've experienced more than once in talking about values. Nice idea, but this isn't how grown-ups build public programs or build social programs. On the one end of the spectrum, and then on the other end of the spectrum, the notion that somehow to ever admit that we have problems in our healthcare system is to be a traitor to the system. And that's equally unacceptable, because anyone who works in our healthcare system or uses our healthcare system as a patient knows how deeply imperfect it is. I bring you good news, however. which is actually that pretty much any problem you can pose on the long list of challenges that I started out with, we've actually figured out an answer to. The problem is we seem to have difficulty implementing. And you've heard Neil speak about this earlier. So actually the great example of access to the personal health record is a terrific one, because I work at a hospital just down the street where if you happen to be a patient at Women's College Hospital, when you come into our organization, you can download an app and you can access your lab results, you can access your medical imaging results, and fairly soon you're going to be able to access every single clinical note and every single piece of information in your health record on your mobile device. And hopefully by this time next year, you're also going to be able to have an interaction with your doctor or your healthcare provider using that mobile app, sitting in the comfort of your own home. But we've got that at Women's College Hospital. There are a whole bunch of other innovations that are happening in other organizations that we don't have. And it just happens to depend, doesn't it, on where you live or which organization you happen to walk into or which doctor happens to be your family doctor, whether it is you have access to a nurse practitioner or whether or not you have access to e-prescribing or whether or not you have access to your personal health information online. And so I want to be clear that I do not believe that we have an innovation problem in healthcare. And actually the Naylor report spoke to this, I think, quite eloquently. We have problems solved 10 times over in this country, one for every province and then for good measure in each territory and all of the federal health programs as well. Our problem is in the spread and scale of those innovations, in making them universally accessible to everyone so that no matter where you live, you can have some reasonable expectation of consistency. So the premise that I begin from then, when I talk about big ideas to improve healthcare, and don't worry, I'm not going to list all 6 of them, also because I hope you read the book. I hope you notice the beautiful book table on the way in. The premise that I begin from is that the best way to ensure the ongoing commitment and support for Medicare that I believe it deserves is to make it excellent. And I do not believe that that is beyond our grasp. I don't think that it is an unimaginable future. So I'm just going to give you a little taste of what's in the book, and one of the people in particular, because I said, as I mentioned earlier, that the purpose here is to have a bifocal conversation. So I'm going to take you from the individual to the big idea, and I'm going to tell you about a guy in my practice who I call Ahmed, who I see on a regular basis still. He's a cab driver in downtown Toronto, an immigrant, South Asian descent, lovely guy, big smile, unfailingly polite, always on time. He has a beautiful wife. He has 3 kids who are the center of his universe, and he brings them all in for their appointments. I tell the story in the book of how I once hailed a cab in downtown Toronto, and he was behind the wheel, and he absolutely refused to take my money. He's a lovely person, and he's got a problem. Now, he's got high blood pressure, and he's got diabetes, and he has high cholesterol. But actually, none of those things are his problem, because all of those risk factors for heart disease and stroke are things that we know what to do about. And there's a rich literature around what the lifestyle interventions and the pharmaceutical solutions are that could substantially reduce his risk of developing blindness, having to have a limb amputated, having a stroke, or having a heart attack in the coming years. So the problem is not that he has these sicknesses. The problem is that he doesn't have drug coverage. Like every cab driver in the downtown core, like every self-employed individual, like every person who's working a part-time job or a job on contract or is in between their parents' coverage and their future full-time work, if such work is ever going to exist in Canada anymore, like all of those people, Ahmed is in a situation where, just like my grandfather, when he's got the money, he pays for his medicines, and when he doesn't have the money, he just lets it slide. And he makes the same choice that any of us would make if we were in that circumstance. This isn't somebody who doesn't care about his health or doesn't understand that he's taking risks. This is somebody who, at the end of the month, is going to make sure that he can pay for his kids to go to camp this summer before he pays for his own prescription. And any of us would make the trade-offs and the choices that he is making. But it's a terrifying set of trade-offs and choices, because I watch him and I know there are periods of time that are long where I don't see him. He just doesn't come, and I know that he's not coming because if we take his blood, I'm going to realize that his numbers are out of control and he's not managing his chronic diseases well, and he's embarrassed. He doesn't want me to know it. And so he only comes in when he's managed to kind of scrape it together to take his medications for a few months. And over his lifetime, what he's doing is exposing himself to a risk of having a catastrophic event, which you and I as taxpayers will pay for his care when that happens. When he has his heart attack or he has his stroke or he requires surgery in order to prevent him from going blind, we will rightly, as a society, make sure that he gets taken care of. But for some reason that is beyond understanding, we will not pay the pennies that it costs for him to take his medications appropriately. And this is where we're stuck in Canada. It's one of the 6 things that I talk about in the book, because at the same time that we're paying 50% higher costs in Canada for our prescription medicines than the OECD average, we are somehow managing not to cover everybody. And it is an absurd situation that we find ourselves in. And so big idea number 2 that I have been out there talking about, and I'm certainly not alone in talking about it, none of these, by the way, are my own ideas, is universal pharmacare, the inclusion of prescription medications under Medicare. Now, those of you who are under 25 in this room will know that the Ontario government announced in its recent budget universal first dollar pharmacare coverage for children and youth in the province, which is amazing news. And that means that until you turn 25 in this province, you are taken care of. And then when you turn 65, we take care of you again. And in the middle, there is this big hole in the donut where we're just going to let you figure it out. Right? And so I don't mean at all to underestimate the importance of pharmacare for children and youth. I think it's a critically important step, but we should not pretend that this problem has been solved in Ontario. And if you live in British Columbia or if you live in Atlantic Canada, you're going to find yourself in yet another different situation. I want to wrap up by saying that, there's Ahmed, there's Susan, there's Abida, there are a whole number of people in this book who I talk about the things that I've learned from them as a physician growing up, learning from my own patients, and the things that I also have learned about the healthcare system as a result of my own research and work. And none of it prepared me for what it's like to touch that nerve of pride that we've talked about today about Canadian healthcare. I felt it, I had the experience once with the YouTube thing, which was very bizarre. And I've had it since then in this experience of traveling around the country, talking to people about the healthcare system. If you want to know what it's like to unleash something unimaginably big, try writing a book about Canadian healthcare. The stories that come at you when you do something like this are amazing, and they will make you cry, sometimes with pride and sometimes with shame. I have an inbox full of them. I get handwritten letters from people telling me about their experiences in the healthcare system because they read the book or they heard me talking on the radio, and it somehow evoked a reaction in them, usually to do with their own personal experiences. So there was the guy from actually the GTA who wrote to me and said that he is quite certain that the Canadian healthcare system has saved his life twice. First, when he had a heart attack, and secondly, when he had cancer. But as a result of his chemotherapy, his mouth is now full of sores, and he can't eat solid food. And do I know a dentist who might be willing to put him on a payment plan to try to fix his mouth? There is the guy who said to me, I live in a motel in Northern Ontario, and I heard you on the radio talking about the importance of having a family doctor and not going to walk-in clinics. Don't go to walk-in clinics. We'll talk about that later during the question and answer. But he said, I live in this motel and I mostly drink all day. And my wife doesn't talk to me anymore and my kids don't talk to me anymore. And I go to the walk-in clinic for refills of my bipolar medicine. But I heard you talking about the importance of having a relationship with a family doctor, and I wonder if you know somebody who would be willing to have that kind of relationship with me. I think I kind of expected, to some extent, that people would bring those stories It is part of what you sign up for, I think, when you put yourself out there on a topic like this. But I will tell you the thing that I hadn't expected, and this will be the final thing I say. I had not expected the nurses' book club that showed up to my launch event in Ottawa with their copies of the book under their arms. One of them actually had sticky notes already marking the passages that she wanted to discuss. And they said, we're retired, a group of nurses. We worked in the healthcare system for 30 or 40 years. We're now interested in these topics, and we read your book, and we agree with your ideas. What can we do to help? And this is where we come full circle to the conversation I would say is not a conversation about patient engagement, it's a conversation about citizen engagement. What are the receptor sites for the public who care about this healthcare system and want to see it improved, who are willing to participate in meaningful ways if we would give them something to do? What are the receptor sites for those Canadians who care? I suspect that you are all here because you would count yourselves in that crowd. And because of course the answer is that I am not going to do it alone, and Neil is not going to do it alone. It's going to take all of us. It's going to take the Nurses Book Club. It's going to take each of you to figure out what are the ways in which we can participate to make this healthcare system worthy of the tremendous pride we have in it. Thank you.